3 NHS leaders are taking part in our discussion. Arthita Daz is a consultant psychiatrist based in Derbyshire. She specialises in eating disorders and has several senior educational roles.
How do you start making those social connections, those human connections?
For me, it's about self.
Cara Afzal is the Programme Development Lead for Health and Implementation at the Greater Manchester Academic Health Science Network.
It's all well and good going on training courses.
She's responsible for leading large-scale transformational health and social care improvement across the Manchester conurbation.
Attending lots of courses.
Eddie Oller is the Director of Nottinghamshire Health Informatics. His role includes pushing technological boundaries to improve health and social care. They're sharing their personal experiences around race, power, diversity and inclusion with NHS Leadership Academy faculty member John Deffenbaugh.
Welcome back. It's good to see you again for the kind of next stage of our conversation. And in the meantime, there's been lots of ongoing coverage about diversity of boards, diversity of leadership across business and the public sector. And I'm curious what your views are about the intentional or kind of unintentional barriers to being able to improve diversity across the NHS.
From my personal experience, barriers are put in place where you're not given access to certain levels in terms of the meetings, and some of the reasons that you're given is that it's funny that the behaviours there you don't want to see. That's one of the reasons.
The behaviours you don't want to see.
You don't want to see
right.
In action. So in essence, what I'm being told is I'm being protected from that in some way. And that perplexes me, because I think to myself that shouldn't we be at that level? Shouldn't you open it up to a more diverse representation of different individuals that could basically counterbalance those if there are certain behaviours being exhibited that And also, I think if you're not a part of those conversations, and you are not able to learn from being a part of those conversations, then you have a skills deficit, right. What I call, because you can pick up cues and you can pick up learning, and invariably I do by observing some of the leaders that I have the privilege of working alongside in different ways, and I feel very outward on the periphery of observing this. And for me, I want to be a part of those conversations. So I'm not saying it's an intentional barrier, but invariably I'm told that that there is an opportunity really for you to be a part of those conversations.
How did you respond to that then, if you were told you couldn't get in, or that you were being protected?
I think I challenged back and said, wouldn't they? And now, as I'm getting older, I think I'm getting braver as well in my challenge back to have those conversations, to say that then that is absolutely a reason why we other people in a room can change the dynamics. It's all well and good going on training courses, because there is statistics around, I think, minorities having lots of qualifications and attending lots of courses. But I think if you're not a part of those conversations, you are, as I said, skills deficit. You will not be able to articulate yourself clearly in those meetings, because there is a language, a way in which board level language operates, and that if that remains a hidden language and you don't acquire those skills by being a part of that, immersing yourself in that, then I think it will be a barrier to us moving forward.
You say you're challenging back, and clearly you've got to that stage in life where you do have the confidence to challenge back. But what I'd add is that a lot of people from BME backgrounds, especially those who were born overseas, have a very hierarchical view of society, especially, and of organisations. So being able to challenge back and be able to challenge people who they see as their seniors is even more difficult for them culturally, isn't it? I suppose what I'm saying, John, is that people listening to this conversation will think, well, if you want to be part of that conversation, why don't you just ask? But I think for many people from BME backgrounds, it's not that straightforward, because it's overcoming their internal inhibitions about approaching somebody who may be one grade higher than them, but sits very much in their sort of hierarchy, or I can't possibly approach them. If they say no, that's it. That's a definite no. I can't challenge back.
Excellent manager I had many years ago at Central Manchester, she said to me, well, you know, you have to go through certain things to learn those things when I was going through a difficult time, and I think she's absolutely right that you, as you grow and you experience those experiences, that's how you modify your behaviours, you change your behaviours, and you learn.
From where I see some unintentional barriers being set are particularly around the recruitment process, again in support of what Artie said, which is around the values that are based on the one, qualifications, or the two, the skills sets or the diversity of thinking that's required are not high enough to represent the community. And I know we've had that discussion quite a few times now, but I do think that something has to change in the sense of what are leaders, what are the skills that leaders are recruiting, looking for when they take on for talent, regardless of their ethnicity or gender.
Yeah, well, interesting. When we talked last time, we talked quite a bit about the kind of attributes you saw in NHS leaders, the attributes you were looking for that you'd like to see, and this is now putting yourselves in your leaders in your own right. And what I guess I'm curious of is what would you as leaders like to do in your own right to be able to influence leadership in the NHS?
Certainly for me, it's to create more leaders. So I think the more courageous leaders, rather than create followers, it's to create leaders who can create the right environment, respectful, caring, compassionate, thinking about inclusivity rather than just about diversity, and creating that safe environment for people to feel open that they can do that. So
tell me what you do in your own leadership role then, Eddie, to create leaders of the people who report to you as leaders in their own right.
I have a personal coaching development plan that I put together through all of my direct reports, but also I do a session and supported by the Trust Equality and Diversity training, and that's around allowing people to raise concerns, but also speak openly and not have a fear of reprisal. And I think the more you can create that environment, the better it is. And the evidence that certainly in my organisation I'm starting to see is that people will raise concerns about bad behaviour if they don't feel congruent with it. So in the sense that they will raise it. And this is coming from not just BME backgrounds, but also from all walks of life, where people are buying into and understand the values of the organisation. And once you create that environment that is an open, safe, compassionate environment, I think people will grow as leaders and feel safe.
I have different roles. I'm a clinician, but I also have several roles in medical education. Over the years, I've mentored quite a few junior doctors, peers, supported them through the interview process. And recently, I've become much more specific about who I do that with. So before, whoever approached me, I'd take up that relationship. Now, I tend to focus on not just people from BME backgrounds, but specifically doctors who trained overseas, because in terms of exams and career progression, they're much more disadvantaged than doctors from BME backgrounds who trained in this country. So kind of bringing out the nuances in sort of barriers and bias there. I'm also a little bit of a rebel and an agitator. I'm learning how to do it in a kind way rather than in a way that is repulsive and puts people off. That's still a developmental journey for me, but I like to throw a pebble into the pond and watch the ripples.
Give me an example of the pebble in the pond.
So in my role as a foundation training programme director involved in medical education, I had to do the Senior Medical Educators Induction, which was a e-learning package. And this was a 2.5-hour induction with interviews from, as they described it, senior medical educators. And out of all the senior medical educators, and there was quite a few involved in the video, there was one person from a BME background and one female, and all the rest were white males. And if you think about the population of doctors, doctors and junior doctors especially come from a variety of very diverse backgrounds, certainly ethnically, if not in terms of social class. And noticing this incongruity, when I met with one of the senior medical educators who is responsible in terms of producing, I mentioned it half jokingly, half seriously. How do you think that appears to doctors and junior doctors who are watching that? What do you think their perception or experience of that is? I didn't pursue it any further, but I just left that with them for it to sit with them. And I know that I will return to that conversation. There's no need to sort of shove it down their throats, but it's about sort of starting that thinking, which I'm sure to them that was completely unintentional. There was no desire to exclude people. But how is that perceived? Because perception is everything.
So it's kind of posing that question in an appreciative way to can increase awareness so they can take on the responsibility, which is a coaching approach.
Yeah.
Good.
There's a particular meeting that I thought I would be invited to, but wasn't, and a new colleague was invited to that meeting. And immediately I thought, oh, well, why? You know, I've been here longer. I was on the recruitment panel for that individual. And the elephant in the room is, you know, is it because I'm different, you know? And I thought rather than, you know, think to myself that my face doesn't fit, and I did say that to a colleague, I think my face doesn't fit, and they said, no, please don't, you know, you shouldn't be thinking like that. But you do, you know, because incrementally these experiences, they build up in your mindset because it's not a one-off occasion. It's happened throughout your career, so it's not something that's happened in isolation. So on this occasion, I emailed the individual who hadn't invited me to the meeting and asked if we could go for a coffee.
Right, good.
And I had an open conversation with her, and it was fantastic. It was really nice to have that conversation, and there was a misunderstanding, and she explained to me what that misunderstanding was. And then the conversation when I said to her, you know, I'm quite eager to move into a director role to get a more strategic role and have some positional power because there's changes that I'd like to see in the NHS. And she was wonderful. She gave me some really, you know, good tips and insight. So I think, it's being open and brave. And now I'm challenging my own presumptions and assumptions that I make, and not leaving them.
From your BME perspective, I can call it that. What kind of tips or quick wins or do's or don'ts or kind of takeaway messages, you know, do you have for chief executives, you know, in there being able to tackle some of these issues that we've had, you know, quite a rich range of conversations about?
I would say be brave, and if you're going to have those brave conversations, prepare for them. Rather than sort of in the corridor, off the cuff. Prepare for them.
That's a really powerful point, that second about prepare. You know, actually take the time, think about it, prepare. You know, because NHS leaders, and you've been through top leaders, you know, pace setting, you know, on the hamster wheel, do. Take the time off, prepare. Excellent. Eddie?
I think as a leader, you need to pay attention to how you're really feeling. And I think that there's three paradigms to think about when you're paying attention to how you're feeling, how that might play out. So your own self-awareness about the values and things that are happening in your organisation. How do you really feel? And pay attention to that. Secondly, I would recommend that they walk the corridor. So you walk the corridor and find out how the staff are feeling, and really ask the question and then take time to listen. And then thirdly and finally, which is probably most important, if you take care of the staff and look at and think about and listen to what the patients are saying, so have some direct feedback from the patients group and bring together the staff element and the patient's involvement, then I think that's a really important, powerful tool in order to make sure you're a good leader.
I think you need to open yourself up to new experiences. The relationships between the citizen and the state and healthcare is changing. And I think if we're slow in embracing that, we're going to be slow in developing a healthcare system that will meet the needs of our population. Some of the ways you can access that information around your communities is actually delving into some of the information that's available on the World Wide Web. It's at your fingertips, you know. So my top tip will be to use your time effectively. And if you haven't got the time to go out and walk in the communities and immerse yourself in the communities, then at least broaden your horizons by understanding and reading more broadly as well, you know, opening yourself up to those cultures, and have those open conversations with staff,
Well, I mean, for each of our conversations, there's been a richness of results that have come out of that, and recommendations and insights, and I'm sure that will benefit chief executives. And I'd like to keep in touch, and I'm curious to hear how you get on in your own careers. And thank you very much for contributing to this conversation.
Thank you.